Hello, everyone. Thank you for joining. This is the Georgia Land Continuing Education webinar. The Georgia Leadership Education in Neurodevelopmental and Related Disabilities program is a one-year interdisciplinary training experience that helps prepare future leaders to provide coordinated, culturally competent, and family-centered care. The Georgia Lynn Audiology program specifically helps address the needs by preparing an audiology workforce to further this Georgia Lynn mission and improve systems of care in Georgia. I am the Georgia Lynn project coordinator, Tiana Moman. So this is a little bit of housekeeping for while we are in the audiology webinar. If you have any questions, please put them in the chat. Georgia Land is approved by the American Academy of Audiology to offer CEUs for this event. At the end of the webinar, we'll have a QR code and a link in the chat to complete the post-event eval and assessment to receive credit if you would like to. And then we will send out certificates 3 to 4 weeks following the event. This presentation specifically will focus on reviewing the best practice, processes, and tools for screening development. The particular focus will be on the standardized screening instruments for broad development or for autism that can be administered by audiologists. And we will have a recording available on our website following the event. I'm going to pass it over to our audiologist, Mandy Beck.
Hey, good morning, good afternoon, whatever it is where you are. I am Mandy Beck. I am the audiology faculty member specific to the Georgia Lend project. I'm really excited about this presentation. I do feel like it's something that is very topical, especially if you are seeing children. Do you mind going to the next slide, Tiana? So today I want to introduce our speakers. We have a few of them. Angela Bonino. Dr. Bonino is an assistant professor in the Department of Hearing and Speech Sciences at Vanderbilt University Medical Center and the Division Director for Pediatric Audiology. Current research is focused on advancing hearing health care for children with developmental disabilities by identifying gaps in clinical care and improving behavioral hearing assessment procedures. And we'll obviously talk about some of this today. Deborah Mood. Dr. Deborah Mood is a GaLEND trained licensed psychologist specialized in working with children who are deaf and hard of hearing and children with neurodevelopmental disabilities. She's an associate professor at University of Colorado, Anschutz. I always say that wrong every time. My apologies. School of Medicine, Department of Developmental Pediatrics, where she serves as the lead psychologist on the Developmental Behavior Pediatrics DHH team. And then I'm really excited. We have two practicing audiologist perspectives that are sort of going to put what we're learning today into practice and sort of answer some of the questions that can come from, okay, that's great information. I actually work in the real world, and so I'm really excited about that portion as well. So Alyssa Fastnight, who is an audiologist at Vanderbilt University Medical Center. She has 8 years of experience in the areas of pediatric diagnostics, hearing aids, and APD. Dr. Fastnight completed her training at Wright State University for her bachelor's and then Vanderbilt for her doctorate. Lindsay Wheeler. Dr. Wheeler is an educational audiologist at Vanderbilt University Medical Center. She has over 15 years of experience in pediatric diagnostics, amplification, and educational audiology. And she currently serves on the Tennessee EDDI Advisory Committee. And then probably the most exciting, we also have our family perspective today, and actually what we're going to start with. Shravani Gadreddy. She is a mom to an amazing 11-year-old son with autism and profound hearing loss who wears bilateral cochlear implants. He was diagnosed with autism at age 2.5, and shortly after they learned about his hearing loss, they also learned about a few rare vision conditions, all before he was 3. So those early years are really overwhelming, and so she's excited to sort of show how important it is to be deeply involved in his care. Next slide, Tiana. So I will now hand it off to Shivani.
Hi, greetings everybody. My name is Shravani Gadireddy. I am a parent to an amazing 11-year-old child. We He's 11 years old now. We started off the journey when he was around two and a half. So, first of all, I would like to thank everybody for giving me this opportunity to share our family story and also my perspective in collaborative care. Um, so I I'm able to see only the screen. Miss Bandy Beck. I did not know how to go to the
Okay.
slides.
Are you able to see the slides?
No.
Okay. Are you just seeing the person speaking?
Mm-hmm.
Okay, so on the top of your Zoom screen, you should see webinar, and then go ahead and click on Tiana Moman's
Got
screen.
you. Got you.
Yeah. All
Thank
right.
Yeah, thank you. So this is my son Kaushik, and he's 11 years old now. And when we started off, he was diagnosed with moderate to severe autism and a profound hearing loss. And then eventually we got cochlear implants for him when he was 6.5, 7 years old. And he also was diagnosed with very rare vision conditions. And all these occurred by the time he turned 3, like before he was 3. So I'm going to share a few things about him, but when we started, the major concern was that, he was a very happy, caring, and loving child. That was one of the reasons that delayed the diagnosis as well. I'll share about it. And he's exceptionally talented artist. He has really great picture perfect memory, and he's like very determined and self motivated. So that actually helped us a lot in helping him, right? And I want to share that, the collaborative care and a team of people who cared for him along with us as a family. We have, like, the saying goes, it takes a village to raise a child. So we have been blessed to have so many professionals in our journey who helped us with his progress, and through their support, we achieved, I should say, a lot of things that we did not even hope for initially that were possible. Yeah. Next slide, please, Tian. Yeah. So, like I was sharing, he was diagnosed with autism at 2.5. I did definitely have many concerns when he was less than a year old baby. Um, like classic symptoms of not having eye contact, not responding to the name. I did not even know the word autism at that time, and there were not many uh, people around us who were, traveling the same journey. And it was really hard to understand. For me, it was hard because I did not have any knowledge. And profound hearing loss was soon identified after. All this happened when he was between 2.5 to 3 years old. So the vision conditions, we started observing some, vision issues when he was just a 3 months old baby. But then we did not get any diagnosis because he was too young, and it continued in this 3 years. In that 3 years journey, we have been going to visit multiple care centers, but there was no official diagnosis. But by the age 3, we had so many things going on. It was very, very uncertain what is happening. We did not even know the terminology in the first place. And understanding each and every diagnosis was very difficult. How to navigate, who to approach, what kind of services do we need to do, and how can I help him at home? All these things were very confusing, and we had to make a lot of decisions rapidly, which was like, because we all know that the importance of early intervention. So if we delay because of acceptance or because of getting the service, whatever may be the reason, it would delay the overall progress. That was our situation. I'm specifically mentioning this because there was so much denial in our household, except for myself. Like, everybody in the family were against, like understanding actually what is it, and also the accepting was delayed. So that was a biggest challenge, because if we do not accept something, we cannot even get help for him. So that was a very tough situation for me at home. Yeah. So later, it was through our audiologists and first thing our a pediatrician. We started off in Atlanta. Before that, we were in North Carolina. So it was a major step when we moved to Atlanta. That's where I found all the professionals, and to navigate all the systems, of care. We have been seeing like multiple professionals. It was a lot of evaluations and then appointments. My like daily routine itself was very overwhelming, because I had to log what are the places I contacted. Parent to parent of Georgia was there, and I made a list of therapy centers who are doing at home services. And then what are all the first thing I did not know, what are all the services that we need to get for him. So we started off with Babies Can't Wait, and then from there he was transitioned into the school system. So through school, we were getting vision therapy, deaf and hard of hearing services, and of course special education support. And privately, we did speech therapy, occupational therapy, ABA, and auditory verbal therapy. So in between all these things happening, so we had interdisciplinary team involved, and it's a lot, because what I understood very early is that not a single professional, or not myself as a parent, nobody can see the child as a whole, like alone. They cannot do it alone, because autism will limit the way that he communicates or perceives. Understanding, like comprehending difficulty was there, and audiology was one thing, like he was not able to hear. And we started off all these services before he even got his hearing aids. Initially, it was not profound loss, it was moderate to severe, but it progressed to profound loss very, very fast. So having autism and lot of self-injurious behavior, comprehension difficulties, and the way that he is not able to understand and hear, and also the vision difficulties, so multiple issues at the same time. How can we help him in this kind of situation? It was very, very challenging. And Miss Mandy was our audiologist at school. Initially, it was like, we were switching between uh, people at school who worked with him, because based on the availability. But until she was on board with us, we actually did not know what kind of situation he was facing at school, because I do not get an opportunity to go see what is happening in the classroom. He was in self-contained classroom setting before he was 3, but at 4 he got transitioned into an inclusive classroom setting, where he was having a special education teacher with a small group. He was in the general stream, but with a special education small group included in the same classroom. So until then, we did not, we definitely had vision teacher, but we did not have enough idea of how to help him. And as a parent, I did not know what kind of devices will be there for him at school, in the school system and all, right? So one day it was like when Miss Mandy was visiting him for audiology services, she noticed that he keeps running back and forth to his chair and to the board. So during that time, definitely she noticed that he is very self-motivated, because she shared one point that really, moved me. She told, like, he is a child who is not going to give up. So if we do not help him, what is the point of the whole system? So talk to the vision teacher or whoever you need to and get things done. So that's when the whole story changed, because imagine he cannot hear, he cannot, even if he hears, it's not like, because he lost all that 3 years of hearing. He passed the newborn baby test, but the hearing loss was still there. From, we can understand how much he missed hearing all those 3 years. And all of a sudden, after three, if we are putting hearing aids on him, that doesn't mean that, he understands everything. So I had to teach him at home, like, in broken sentences. Kaushik, come sit here. So it was like, Kaushik, eat, Kaushik, sit, Kaushik, hungry. That's it. There was no grammar, there was no full sentence, nothing. But it all started like that, with broken sentences. And first step was to teach him what word means what. So we used a lot of material at home, and at school he had a vision through which he, like, a vision schedule. And the care that we got from school, I would say that, it really helped a lot, because it was very structured. And right after that, when he comes home, we have the ABA therapist waiting for him already. So I would like to share one thing very important here. Initially, we did not understand how the collaborative team actually works. So I had to carry, suppose if I have a pediatrician's appointment, and next I have an ENT doctor's appointment. So I have to carry all the reports from here to there, and next from there to audiology, and from CHOA audiology to school system. So I was the person who was, carrying reports from here to there and keeping everybody on the same page and explaining. So if it's an audiologist, she would definitely be focusing much on, uh, audiology department, like audiology area of help, that what she can do. But at the same time, I had to explain, because of being on autism spectrum and because of having some low vision, he may not be able to do everything if only one area is being focused. So that was the part. But our pediatrician and Miss Mandy both were the first people ever to do that collaborative care on their own without me having to ask for it. Then I realized how easy it makes it for a family. If one small step is, eliminated there, I do not have to do that. She would already coordinate with CHOA audiologist, and she would get all the information. So that really helped, because as a parent, I'll have a perspective of my own. But as a care team, if they both are interacting, and what they observe in the sound booth or in the during the testing time, that also adds a lot, because end of the day, the way that the implants are programmed, that is what, helps him hear. So that collaborative care was very, very important for us. And realizing that, we took it further to explain everything to our ABA therapists at home, and the same thing was passed on to the auditory verbal therapist who was helping Kaushik after he got his cochlear implants to train him on speech. Next slide, please. Yeah. So together we all worked all these years. I am very, very grateful for all the people who have been supporting us in this journey, because it would not have been possible if even one of them was not on the same page with us. It's like a group of people who worked and helped him. And this collaborative care is what helped Kaushik achieve phenomenal things that I did not even imagine it would be possible in future. I had no idea that he would say few words also initially. But today he is in a magnet school for high achievers, and then he is really blessed with art. And he recently gave a TED Talk in November 2025. And he also learned self advocacy, which is very, very important, because as he's growing up, more independence is expected. Uh, so we are still working on that, but definitely at school and through his other therapists and providers, we are able to achieve this as a team. So I'd like to thank everybody today for giving me this opportunity, and please take a step from your side as well when a family has difficulty accepting. I would believe that, sometimes it may not be taken easily when, as a professional, if you, point out something like, maybe he or she needs help in another area, right? So understand a family's perspective and try to help a child. Thank you.
Thank you so much. I love that, just that perspective and all of that. I really appreciate your openness and your openness over the years we've worked together. Do you mind if I share his TED Talk link in the chat for everyone to watch at another
Yes,
time?
please.
Okay, I will get
Yeah,
that and share that
I'd be
too.
great. That would be great.
Yes, yes. Very proud of him. So now we will switch into the next portion of our discussion. All right, Dr. Mee.
All right. Well, that's a very hard act to follow, Shivani. But I really appreciate the opportunity to hear your story. And there were so many parts of it that were so impactful that I think blend well with what we're all here today to talk about, which is best practices for developmental screening by audiologists. And I'm going to touch on some of those points. I just want to we were all introduced. Thank you so much for the lovely introduction, Tiana and Mandy. These are just some of our disclosures, the business piece of things. Before I get started, we just want to talk about the agenda for the second portion of today's webinar. So Dr. Benino and I, as well as Dr. Fosnight, I'm sorry if I'm mispronouncing your name, and Dr. Wheeler, we'll be talking about sort of some terminology and our vision for how audiologists can be involved in developmental screening. We'll talk about the prevalence of developmental differences in clinical populations. We'll talk about a developmental screening process and what that can look like, and some tools that can be used by audiologists and other professionals to screen for developmental concerns. And we'll talk about how to communicate results to families and how and when to refer to primary care regarding developmental concerns. I want to touch base real quickly on some terminology that you're going to hear us using throughout the day so that we can all be using shared terminology. When we talk about developmental status, we're really looking at ways of describing children's development across a variety of developmental areas, including communication, cognition, motor skills, social emotional skills or behavioral skills, and sensory processing. And so when we talk about developmental disabilities, when a child has differences in any of these domains that have an onset in early childhood, but are expected to last throughout the lifespan, we use the term developmental disability. So although children may make gains in particular areas as they develop, the differences in their development are expected to persist to some degree across childhood. So these might be things like autism, intellectual disabilities, Down syndrome, cerebral palsy, whereas developmental delays also may reflect delays in a particular area or one or more areas of development in early childhood. But with intervention, some of these concerns may resolve, such as articulation concerns. So those are the primary differences, and we're going to be talking about both developmental delay and developmental disabilities today. We sometimes just broadly use terms like developmental differences, and you'll also commonly see terms like neurodiversity used in other platforms, which is just a way of describing any kind of brain-based difference. And so we'll be using all those terms today. We just want to make sure that we are all on the same page as we do that. I want to touch and reflect a little bit before we dive into this about Shivani's story and what resonated for me about that story as we think about this idea of developmental screening and why it's important. And as professionals, I think it's so validating to hear from families what that experience was like for you, because I think sometimes we're scared to have conversations, particularly about things that might feel outside of our scope. But it was really enlightening for me to hear from you, Shivani, like how important that was for you, that you didn't perceive it as outside of Dr. Beck's scope when she talked about vision concerns for your child, even though she's an audiologist, right? In fact, you found that quite helpful and validating. So I think as professionals, sometimes we might feel concerned about what a parent's response will be when those concerns are brought up. But you very clearly communicated how important it was for you to engage with professionals who listened and who were taking into consideration all of your child's unique needs and who kind of walked along with you on that journey towards kind of figuring out what those needs are and how to best support them. And that's really what this entire presentation is about. It's about how to help audiologists kind of learn how to identify those developmental concerns and support families and validate those concerns and know what to do when they're identified. It was also so striking to me to hear that your son was diagnosed with autism before his hearing diagnosis. And that's something that's so important to consider, because when children have unique developmental needs, sometimes our test procedures, like our audiological testing procedures, really weren't developed for kids who don't follow those typical developmental trajectories. And so that can result in complications with diagnosis of hearing differences and things. And so having an understanding of development and being able to recognize those indicators is so helpful for all of us as professionals. And then I think also just that idea of audiologists have like such a unique position. I'm not an audiologist, but I fashioned myself to be closely aligned with audiologists because I spend a lot of time with audiologists and with kids who are deaf and hard of hearing. And it's so remarkable to me what a unique position audiologists are in, because they are often seeing kids early and they're often able to track them sort of across the lifespan sometimes. And therefore, sometimes across systems that to families can feel so disconnected. So it's such a nice opportunity. And I think one of the reasons we feel passionately that audiologists can be and should be involved in developmental screening. So I can't thank you enough, Shivani. That was so helpful to hear your story. And I think we'll return to some of those themes as we continue with the presentation. So here's the big picture of vision. Dr. Bonino and I also met through the GaLEND Leadership and Education in Neurodevelopmental Disabilities program here in Colorado when she was here in Colorado. And we kind of share this like passion for supporting children with developmental differences. And we really feel very strongly that children with developmental differences have a right to timely access to high quality hearing health care and to interventions that support language acquisition as well as all of their developmental needs. And we know that timely diagnosis of hearing or developmental differences is so critical to maximizing outcomes. That's been well established in the literature. I see it again and again clinically in the kids that we see early who are receiving an early diagnosis compared to kids who come in later. And I think one thing that is really important to recognize here is that sometimes the interventions that are needed for children who have hearing loss versus children who have other developmental differences are quite different. And therefore being able to screen for those differences and to be able to refer families to additional supports and services can really optimize care for them. And again, I think help create systems that are better meeting the whole child's needs. So there are many, many factors that can influence, I don't know why there are many, many factors that can influence high quality hearing health care, including audiologists' knowledge about development and their own implicit biases, social determinants of health, the testing methods and procedures that we use, some of the systems in which audiologists work, and whether they work in favor or against supporting the developmental needs of children. But today we're really going to focus a lot on some clinical practices and setup, and particularly that screening piece of things. So I just want to highlight that, practices vary across settings, but in a lot of practices, how we approach hearing healthcare can be based on sort of like traditional practices where methods of audiologic testing are based on a child's chronological age or kind of based on the audiologist's ability to quickly adapt to what is in the room with them and what the child's needs are in the room with them, but without sort of an intentional way of planning for that and planning ahead of the visit to support the child. And one of the things, the focus sort of today's presentation is the implementation of developmental screening in a more formal way, both during visits and sometimes ahead of visits when possible. I just want to highlight some other things that we can see in traditional practice and how they might be discrepant from developmentally informed practice. So in a lot of traditional audiology testing, the implied reinforcement for the child's behavior is based on social praise or aspects of the task itself. But for a lot of our kids with developmental differences, social praise isn't actually reinforcing. And in fact, it can be overwhelming. And some of the toys and activities that are chosen may or may not be reinforcing to a particular child, depending on their particular interests and developmental skills. We also kind of have a lot of assumptions that children are able to complete certain parts of testing, like being able to shift and divide their attention and transitioning between activities during the visit, and that they can tolerate certain sensory experiences. Whereas developmentally informed practice helps us recognize, oh, we need to be more intentional about that for kids with developmental differences. We want to reduce transitions, be intentional about how we address sensory sensitivities like wearing headphones, and really pay attention to the language that we use to explain tests to make sure that it's developmentally aligned with the child's functioning, just like Shivani explained how she modified her own language for Kauchik. And how important that was. We also, in some settings, such as a pediatric hospital setting, such as where I work, there are some system things that impact how quickly kids come back when they're not able to get a complete behavioral assessment. So sometimes that means the kids are coming back several weeks or even months later, whereas developmentally, sometimes kids need the opportunity for serial appointments to allow for gradual desensitization or to benefit from repeated learning trials. Excuse me. And we don't right now have a lot of great guidelines beyond the birth to 3 age range of the EDDI system for, how many times do we try additional behavioral assessments before moving to other methods of obtaining a hearing diagnosis. And we know, like Dr. Bonino will touch on this a little bit, but from the literature, that our kids with developmental delays are more likely to have a delayed hearing diagnosis. So all of this becomes really relevant to us as practitioners. So I'm going to go ahead and turn it over to Dr. Bonino.
Thanks. So here at Vanderbilt, we're doing some problem solving today. So in my office, I have both Lindsay and Alyssa who will be presenting later on as the audiologist. And Tiana, tell me if my mic quality gets bad because the Army apparently is doing a helicopter practice on the pad next to us. And they've now done like 3 touch and goes. So we'll see if this is a problem. They just took off. So maybe they will be done after the 3rd one. Debbie, if you don't mind advancing to the next slide. So I'm going to talk a little bit about the prevalence of developmental disabilities. So when we think broadly about the U.S. population, approximately 17% of children in the United States have a developmental disability. It's been a while since the GaLEND Research Institute surveyed specifically the deaf and hard of hearing population, but based on their publicly available data, it was about 40% of parents of children who are deaf and hard of hearing confirming that their child had a secondary disability. So we know that there's a really high co-occurrence of these 2 conditions. And part of that has to do with there's a lot of overlap in the potential risk factors that might be driving why both hearing loss and developmental disabilities commonly co-occur. So if you look at this golden box and read some of those risk factors, especially for the audiologists in the audience, you see genetic and prematurity, low birth weight, congenital infection, you would think I'm listing the risk factors for hearing loss, right? Many of these are on our JCIH risk factors for hearing loss. These are also risk factors for developmental disabilities. And so we have a lot of overlap of potential risk factors and etiologies, both from a genetics, risk factors, thinking about brain-based differences that are highly likely to be co-occurring. I think it's important to remember that within these particular developmental disability groups, we can see differences between the types of hearing profiles that might exist. And so, for example, children with Down syndrome, we know have a much higher rate of conductive hearing loss, but they also have higher rates of sensory neural hearing loss. Children with cerebral palsy, for example, have a very high rate of auditory neuropathy spectrum disorder in addition to sensory neural and conductive. And so I think it's really important to understand what common hearing profiles might be and to make sure when children are coming into our clinical spaces that we're really thinking beyond whatever the current diagnoses might be in their medical record to better understand what other risk factors they might have and what these co-occurring disabilities or conditions might be and how that might be influencing their hearing status. I put this slide in just for background information so you all would have access to it. This is, there's different ways for thinking about the co-occurrence of these 2 conditions. Sometimes research studies look at a group of children who are deaf and hard of hearing and then look at the co-occurrence of developmental disabilities. This slide is doing the inverse of that. It's taking children who have particular developmental disabilities and looking at the likelihood or the prevalence rates of them having co-occurring hearing loss. And so you can see a variety of the percentage of children who have each of these developmental disability conditions, the likelihood of them having hearing loss. And you can see that all of these conditions have a higher rate of hearing loss than what we see for the general population, with the caveat that we do see some differences and some debate around autism and if that rate of co-occurrence of hearing loss is higher among children who have autism than what we see in the general population. But what we do have better evidence about from clinical samples is that within our deaf and hard of hearing population, they have a higher rate of autism than what we see in the general population at the different time points in which these studies have been looked at. Debbie, do you want to add any additional context from that slide? Great. So what I was going to launch into next on the next couple slides is work that Debbie and I have been doing together, looking at a large data set of children. These are all children who received hearing health care at 3 different institutions, either here at Vanderbilt, Boston Children's Hospital, or Children's Hospital of Philadelphia. The majority of the children are coming from CHOP. They're about 75% of the sample, and then kind of split between Boston and Vanderbilt for the other 2 sites. In total, there's just shy of 132,000 children in this data set. And I do want to point out that all of this data was collected pre-pandemic. So I think 2018 is about the last year that data came into this particular data set. The data set has really good demographic diversity in terms of race and ethnicity, and largely reflects the communities at which these organizations are located. And just to point out, it is about 60% boys and 40% girls. And so one of the things that we did was we wanted to look specifically at these 131,000 kids and understand, of these kids who are coming in for hearing health care, what percentage of children had in their electronic health record a developmental disability diagnosis. So we looked at 8 different conditions. Again, we determined these conditions based on their ICD code being in their medical record. You can see under that specific disability category, the 8 different conditions we looked at. So attention deficit hyperactivity disorder, autism, cerebral palsy, chromosomal abnormalities. The children with Down syndrome are not counted in that category because they are in their own group. We also looked at intellectual disability and vision differences, and then a potentially broader category that may in fact reflect more children with developmental delays, but that is the delayed milestone ICD code. So we look to see what the likelihood of children in the data set having one or more of these conditions. And that's what's reflected at the top. And also looking at the number of different types of these developmental conditions they had in their medical record. So you can see 25% of the children who sought audiology care that were in this data set had a developmental disability diagnosis. And 10% of the sample had 2 or more diagnoses in the records. And you can see that if you look at the specific disabilities, we do see variability. That delayed milestone is the highest grouping at 11% of the data set. And then you can see vision differences is also high at 7.4%. And then a lot of these, and then ADHD and autism, both around 6%. And then the other conditions reflect about 2% of the sample. If you'll go to the next slide, Debbie, thanks. And so one of the things I wanted to highlight is, well, how does this compare back to the general population? So what's reported here in this middle column for the general US population, these are numbers from CDC. In the United States, the current prevalence rate for Down syndrome is about 1 out of 700 births, where in our data set, about 1 out of 50 children who walked in for audiology services had a Down syndrome diagnosis. Cerebral palsy, you can see the general population number is about 2 to 3 children per 1,000. And in our data set, it's 1 out of 63. Autism, the most recent up-to-date numbers, which I think came out about a year ago, correct me if I'm wrong, Debbie, on that, but it's 1 out of 31. And you can see in our data set, which is data reflecting about 2010 to 2018, that rate was 1 out of 16. So it's possible that in some of our clinics, that number is even higher than what it was when this data set was collected. But you can see a very high rate of children seeking hearing health care who ultimately go on to get an autism diagnosis. And then the intellectual disability group, we do actually see our data set has a pretty similar distribution as what we see in the general US population. Part of that's probably based on that diagnosis normally happens at older age. And it could be that these kids, like their medical records just not reflecting that for how that diagnosis, when it comes in and who normally provides it. So I think the main thing to point out here is that 10% of the sample of kids coming in for hearing healthcare had one of these 4 conditions. So the next slide on this analysis, and I guess I didn't point out this QR code that I put on here. This is will link you to the published paper that this is these slides are all coming from. And so the next analysis that we did as part of this paper was to look, and we built statistical models to understand what's the predicted probability of a diagnosis being known at the time the child came in to the audiologist based on their child's age at that first hearing encounter. So your x-axis is the child's age in years, and then the predicted probability being shown on that y-axis with high likelihood being on the upper part of that y-axis. You can see we've plotted all 8 of these conditions. You can see just by looking at that, those functions look different depending on what color they are, right? So that means depending on which disability we're looking at, the likelihood of it being known at the time of the audiology encounter is variable. Deb, if you don't mind, I think I have animation in this slide, if you don't mind. There, perfect. So what's highlighted here in the gold box on the figure is the age distribution for the 50% point for the kids that are coming in. So our median age is like 3.5 years. And so you can see what's in this gold box is where we expect about 50% of kids to be coming in for hearing healthcare in terms of their age. And what you can see is if we look like what the conditions that are the more likely to be known because they tend to be diagnosed early are Down syndrome, chromosomal abnormalities, that a lack of expected or delayed milestones code. So those 3 conditions you're more likely to see if it's a 3 or 4-year-old coming in when they come in for that to be available in their medical record. Cerebral palsy tends, and this mirrors with national data too, tends to be more likely to be diagnosed around that same time period they're coming in on average for hearing healthcare. So that's a sort of, depending on what exact age point they're coming in and where they are on that journey and the severity of their cerebral palsy as well. The later conditions, so the conditions that are very much so have low probability of being in the medical record at the age points where you're likely to see the children is autism, visual differences, ADHD, and intellectual disability. So that's one of the reasons we will be spending a lot of time talking about autism and screening for autism is because we know that 70% of children who ultimately have an autism diagnosis in this data set didn't have it at the time they came to see the audiologist for the very first time. And so that's a condition that's oftentimes not going to be in their medical record when you do your chart review prior to seeing that child. So in summary, reduced hearing and developmental disabilities do commonly co-occur. We know about 1 out of 4 children who are being seen in the clinic will either have a diagnosis or ultimately will receive a developmental disability diagnosis in their medical record, and that the audiologists are often seeing children well before they receive a formal diagnosis. Which then kicks it back off to Debbie.
Okay, well, thanks, Angela. I hope I'm so curious when we do this live, we usually do a poll and kind of check with the audience members and see like whether those numbers resonate with you or not. So feel free to like comment in the chat box about whether that reflects like what your experience in your practice is like or not. I feel like a lot of the times we hear from practitioners like, yes, we know we're seeing a lot of these kids, and probably a lot of practitioners tell us they feel like they're actually seeing higher rates than what's reflected in our data. And it's hard to say whether those numbers are true because quite honestly, we haven't been doing a great job about collecting that information and reporting it. This is the first study that I know of where we really identified that this is a large percentage of the population that audiologists see. And we also know that audiology training programs may not include a lot of training specifically on developmental differences, even though that's likely to be a large percentage of the caseload, especially of pediatric audiologists, especially in these medical settings like children's hospitals. And so nobody feels comfortable with something that they haven't been trained in. And so we wanted to talk about screening development. And I think that can feel like a really big, scary thing when you're thinking about, wait, you want me to do something? I'm an audiologist, like that's outside of my practice. But I would posit to you that audiologists are actually really well prepared. They understand screening because it's very similar to the concepts around newborn hearing screening. So we'll talk about that in a little bit. But here's why we think it's important for audiologists to be thinking about this. Audiologists, even though you may not have a lot of training in specific developmental disabilities, depending on the program that you went through, like autism spectrum disorder, you have had extensive training in child development, and it's particularly in language and communication development, and are often the professionals who best understand for our kids who are deaf and hard of hearing what is expected, what is the expected impact of reduced hearing, and therefore are uniquely positioned in particular to be able to screen for autism in kids who are deaf and hard of hearing. And you also have training in administering and interpreting standardized instruments. As we said before as well, you see children. You see children early from the time that they're newborns. You see them often. You're often working at facilities where there are other developmental specialists, whether that's in schools and working with school multidisciplinary providers, or in pediatric healthcare centers like children's hospitals, where there are also departments that are specifically focused on developmental disabilities. So you are well positioned to be involved in the screening process. And in fact, in the literature, there's a lot of evidence that several other allied health professionals, like speech language therapists, occupational therapists, and physical therapists, there is a momentum in each of those allied health fields to be involved in developmental screening and in screening for autism. And I think there's no reason why audiologists shouldn't be among our colleagues in doing that. So here's the other thing. Sometimes practitioners, we did, some of our GaLEND trainees several years ago did a survey of audiologists asking about what their screening practices were and whether they were involved in developmental screening. And one of a very common response from the audiologists who screen was that they feel like it's not within their scope of practice. I think that is shifting a little bit at our institution, and I would assume it's shifting at your institution as well, Dr. Bonino, based on what you're describing. But the ASHA and AAA guidelines clearly state that developmental screening is within the scope of practice for audiologists. And we would argue that doing it can help inform best clinical practice for kids with developmental differences. And you may not realize this when we talk about some of the tools that are used. Audiologists usually meet publisher qualifications to use the screening tools that I'm going to talk about today. So test publishers often have guidelines for what the clinical requirements are of an individual to administer and interpret a screening tool. And so those vary what that guideline looks like across publishers. There's sometimes like a 3-point ABC scale or a 4-point scale, where the lower level of skill are individuals who have no formal education or training necessarily, versus tools where you have to have at least some kind of professional skill development and be a professional degree and be involved in a professional organization. And that's where most of these tools are aligned. And again, that certainly fits with the qualifications of audiologists. And speech language therapists as well, if there are any speech language therapists on the call. So I think the majority of attendees who are practicing as audiologists or speech language therapists are going to find that it's within your scope. Now, does that mean that screening is a billable service in settings where that is a driving factor for whether audiologists participate in it? that has been a question of debate for some time now. And it's my understanding that things may be shifting slightly with some of the new codes that came out this year, and that there may be increased opportunities for audiologists to be able to bill screening. Then it's a matter of talking about the costs associated with the screening tools and developing the programs as well, and whether institutions and practices are willing to take that on. But we will be talking about some free and publicly available screening tools, as well as some that are tools that are paid for by the public, that you have to buy from the publisher today. So we think screening is worth your time. We hope we're going to convince you why. And the good news is you're qualified to do it. So that's exciting news. All right. Okay. So here's why we think it's both to the benefit of the child and to the benefit of the clinicians. If you are formally gathering information about a child's development, it really, really, really can help inform how you modify practices during your audiology visit. And I think, what I hear from practitioners again and again is that, and what we see in the data is that kids with developmental differences are some of the more challenging kids to test. Not because the kids are challenging, but because the tests that we're using were not developed for kids with developmental differences. And so being able to think flexibly about how to approach testing and modify it to meet the child's needs so that testing is more accessible to them really is key for getting reliable, valid results, and also feels better as a practitioner, I think, if you feel like you are meeting the needs of the kids coming in the door. I think it's also, screening is so important because just like Shivani was sharing about, like getting a first diagnosis of autism and then a diagnosis of hearing and then a diagnosis of vision and other concerns, that first diagnosis can sometimes have a shadow effect where then other behaviors that are observed get attributed to that diagnosis. So it would have been really easy for Mandy to attribute the behavior she was seeing in the classroom to autism, right? But being able to kind of recognize how other developmental differences present and potentially being able to screen for them intentionally really helps reduce the likelihood of the shadow effect of that first diagnosis. And we're going to be talking today about how we can both use the information gathered from developmental screening to modify procedures in clinic visits, but also, again, the importance of helping to connect kids who do have developmental differences, if you screen them and identify them, with unique and tailored intervention approaches. One of the things that I often tell people when they ask me, because I am somebody who does both screening for development and for autism, as well as autism diagnostic assessments. And sometimes families will reach out to me ahead of the visit and want to know why that's important. And what I share with them, like, what difference is it really going to make to their child if they do have autism? And one of the things that I share that I see quite often is that our deafness-related interventions are really good at, once a hearing difference is known, identifying ways to make language accessible and immersing a child in language, but that language may still not be available to them if the symptoms of autism, which require social motivation, a recognition of the importance of others in social communication, if those skills haven't been developed, we need to rely on autism interventions to build those skills first in order to make all that rich language environment available to the child. And so it really does sometimes have a very significant impact on what trajectory for intervention we provide for kids. All right, so I'm so curious to know, and I can't really, while I'm sharing screen in particularly, I can't really monitor the chat very well, so I'm going to count on my colleagues to help, and feel free to interrupt with that. But we've kind of started laying the groundwork for like why we think this is important, right? But we also know that a lot goes into whether this actually happens. And there's the policy component that is dictated at all levels, from national guidelines and standards all the way down to individual clinic practices within an institution or a school system. And so sometimes those policies drive what's actually happening procedurally. But we kind of want to lay out sort of best practice in terms of thinking about screening and what it could look like today. But I'm hoping that during the Q&A time that we'll have more time to kind of talk about what you all are seeing in your settings and what that looks like, and how to be part of change if it's something that this presentation convinces you is worth looking at within your system. So I'm looking forward to those discussions. So just to kind of like lay out the foundation here, I think you might see different types of screening strategies from like, I think everybody is probably doing some kind of informal screening, right? You're probably reviewing records, whether they're medical or educational records and case history. You're using like observations of the child in the room to kind of drive what happens when how you meet the child's needs. And maybe using non-standardized tools. And then there's formal screening instruments that might look broadly at development. And we'll talk about these, like the Ages and Stages questionnaire or the survey of well-being for youth and childhood, the communication development inventories, and autism-related screeners like the MCHAT. So, I can't get my animation to come in here. Okay, so best practice, and there's different levels of screening, right? If you think about it, I think it's helpful to kind of draw parallels between what we're talking about with developmental screening and autism screening with newborn infant hearing screening, right? Newborn infant hearing screening, do we screen just the kids who look like they might have a hearing difference? Probably not, right? We do screen kids who have craniofacial differences or things like that that alert us to the likelihood based on physical appearances that they might have a hearing difference. But the bread and butter of the universal newborn hearing screening program is the universal part, that we're screening all children, right, to determine if they have a hearing difference. Not just some children, sometimes in some clinics or when there are concerns without an established protocol. The universal newborn hearing screening program does all of that, is meant to establish that, is meant to establish universal screening of all children and clinical protocols for what that screening looks like based on the JCIH standards, right? So we're familiar with that we've recognized in the field of newborn hearing screening that that's best practice, and we've recognized it for a reason, right? Because some of the informal procedures have been proven not to be as effective as standardized tools. So as I said, I hope we'll have some time to discuss sort of like what you're seeing and what is clinical practice with where the participants today are working. But I'm curious, like, what that range looks like in your settings, whether it's primarily reviewing the medical record ahead of time, whether your systems are specifically sending out questionnaires asking about development ahead of time, or whether you're using some of these formal procedures. And I think a lot of the participants would love to hear from people if they are doing it with formal procedures and billing for it, because again, I'm like a realist about the systems in which we practice and know that that's a big part of the puzzle here. Okay, so just like newborn infant hearing screening, that the protocol for screening should be screening all children using standardized tools. Like, do you remember when people used to screen I still have a pediatrician who has a tuning, what is it called? A tuning fork in their office. And when their screening tool, when their actual tool didn't work, literally the physician pulled that out. And I was like, no, put it away. That's just helpful here. So we all remember that, and the screening tools themselves will change over time, hopefully for the better, the more we're using them consistently and gathering this data. There may be some groups that may need to be screened more often. And we do this with universal newborn hearing screening as well, right? So if kids have congenital CMV, we screen them at birth and then we follow up. If kids have Down syndrome, we screen them at birth, and then there are protocols in place, fortunately, for screening them throughout childhood. And then, and we'll talk about the groups that may need to be screened more often for developmental differences that you're likely to commonly see. And then it's really important, just like with universal newborn hearing screening, we don't want to just do the screening. It's not enough to just do it and check off the box that I did it. That follow-up piece is so important. How the information is shared is so important. Who gets the information is so important. So we're going to talk about all of those pieces. Okay, I guess right now we're going to talk about screening all children. I think I already kind of hammered this point in that we really, especially in the settings that audiologists and the position that you're working in, we really want to be screening all children. So audiologists are usually seeing children with a hearing or a communication concern, right? And if kids are coming to you with a hearing related or a language or communication related concern, that often can go along with autism as well as a wide variety of other developmental disabilities, right? We also saw from Dr. Bonito's slide that like many of the kids coming to you for hearing screening have known risk factors, not just for hearing differences, but for developmental differences. And so when you see those, you shouldn't just be thinking, oh, this is a risk for hearing. But yeah, sometimes it means you want to be even more proactive about getting that information to be able to determine hearing status. But also, part of your role can be to help support the families in identifying if the child has additional developmental needs. All right. The other reasons for wanting to screen all children is, again, to be able to identify those developmental concerns in a timely manner, but also it really, really, really reduces bias. So if you have procedures in place where the screening happens all the time, you're less likely to think, oh, that child during my 30-minute visit was so cute, they couldn't possibly have autism. And Shivani did a really nice job of kind of explaining that her child, who was and is so cute and has so many great qualities, like could easily be missed, right? If we're not recognizing and intentionally pursuing this additional piece of information. We also have to recognize that we're not going to see every behavior in the types of encounters that in which we engage with children. And so being able to collect from other people who see the child across different contexts, again, helps reduce bias and catch more kids who have developmental concerns. I'm not just talking about these things. I implement this in several of my clinics. So I work in a microtia clinic where we follow these guidelines. We screen all kids for development. We screen for autism at every visit, unless they've had it and had it ruled out diagnostically. I see it myself that there have been kids where I've been like, I'm not sure if they have autism, but then I look at the screener and I'm like, oh, yes, this is definitely flagged a concern for autism. And even though I'm well trained to look at it, sometimes it's just validating that part to push me over like whether it's worth the referral or not. So I think it's also far less awkward when the screeners are just given out all the time than if I see a child who has very clear behaviors in the room and then I'm like, hold on a second, let me go get my screener for autism, right? Then that changes the dynamic and how I'm engaging with the parents versus if I were to give it to them ahead of time, ahead of the visit, and then we talk about it. So I think it's less awkward as clinicians if you're doing it all the time universally.
Hey, Debbie, can I ask you a clarification question? Jess in the chat asked about thinking about the demands that are being placed on families who might be getting screenings from multiple different environments, and then they at their site may not be able to see it within their electronic health record, but maybe they're getting surveys from a pediatrician or at the school. And so how do you and I think the question is really thinking about fatigue of families filling out this information. And what are some of your thoughts around that, and thinking about when is it still worth doing it, and what's the rationale?
Yeah, so if I see in a chart that the screener has been done according to the American Academy of Pediatrician guidelines, and I can see that within the chart, or I can ask the family if it's been done and see the results, then I don't necessarily repeat it. If a family says, yeah, it's been done and it's fine, I might have further questions around it, right? Like I might ask them, tell me more. What did you learn from it? What were some of the things that you and the person administering the screener discussed? And I do that because I have had multiple situations actually where families will tell me that they've done the screener and that there were no concerns. And I have access to it in the medical record. And so I can see like, oh, actually, that's not what that result indicates. I can interpret that screener. And so I know actually there were some concerns identified, but perhaps the clinician didn't actually discuss it with the family. They didn't have that follow-up protocol in place. And so that's why I do it. I have to assume that if that's true of the ones that I can see, that there's also a risk of that being true for the ones that I can't see. I also generally find the majority of the time, families are like grateful and welcoming of these conversations. There's few and further between situations where a family's upset about it. If it is something, because I do bill for screening, and if that is a factor for the family, we have a conversation about that. It's in my setting that's pre-authorized. And so they usually know that information up front. And if it's not something they want to take on, I have to be respectful of that. But those are the parameters within which we usually follow at our setting.
I think the other thing to encourage folks to actually understand what your local context looks like. So if you look at national numbers, even though pediatricians have been recommended for a really long time to be doing standard universal screening for autism, there's high variability. And so to really don't assume that the local pediatrician is doing it, I guess is what I'm trying to provide as a warning point.
Definitely. In fact, at my own kids' pediatric office, they have never formally screened for development or for autism. And my child has a unilateral hearing difference. And at 2 years in a row, they have been screened by the procedures used in the office. And I've been told that they don't have a hearing difference, even though they have a sensory neural hearing difference. So that information is not always well understood by the people doing the screening. And for all the same reasons, they may be likely to write off concerns, whereas we as the providers who understand development at a deeper level sometimes recognize concerns that somebody else has written off as no big deal. And I see that all the time, especially with kids who do have an identified hearing difference, where they've screened on the pediatrician screener, but the pediatrician says, that's not a concern to me because they have a known hearing difference that's known to impact communication. And I look at their mild unilateral hearing difference and I think they should have words at 3, right? So, so I think there's a lot of expertise that we bring, and that collaborating with referring providers and outside providers and with families is such a critical part of this being successful. All right. So we talked about using standardized tools. Now we're going to talk about what some of those tools are. So here are some developmental screening instruments. This list is by no means exhaustive. There are many, many, many other tools out there that are broadly used to screen for development. So some of the most common ones that you'll see For young children are the Ages and Stages questionnaire and the Survey of Wellbeing for Young Children. These instruments can be, especially the Ages and Stages questionnaire, can be administered as a parent interview or questionnaire or through observation by the clinician. It assesses broad areas of development for kids birth through 6. There has been, for those of you who are working with kids who are deaf and hard of hearing, there has been some research with that population by colleagues at Cincinnati Children's. Although that operates pretty well as a broad screener, many of these screeners certainly are not sensitive enough to capture subtle communication or language developmental differences in our kids who are deaf and hard of hearing. So I just want to be clear that that is what I'm not suggesting that these just be used for screening language, especially in kids who are deaf and hard of hearing, but that they can be helpful, broader measures of screening development. Some other ones that are seen are the PEDS, the Parents Evaluation of Developmental Status, which is a developmental questionnaire where parents fill out different questions across domains. It can sometimes be touted as a screener for autism. I would suggest that the psychometrics of it and what has been duplicated in independent clinical studies suggest that that probably isn't your most reliable autism screener, but it can be used as a broad developmental screener. Another one that we've been implementing here in certain clinics, because it has such a broad age range of birth to 21 years, is the Developmental Profile 4th edition. And that does screen, again, across development in physical, adaptive behavior, social emotion, cognitive, and communication. That tool does have a deaf, hard of hearing clinical sample, and select items can be modified for kids who communicate using sign language. So it's a broad developmental screener. And for the, there are also like domain specific screeners. You'll see like sensory processing screener tools that we're not going to go into today, like the sensory processing information questionnaire. Or you'll see communication specific tools like the communication development inventories that many of us in deafness are familiar with. Those are available for kids who use both spoken language and sign language. So these are like tools that are readily available to you. It's important to recognize that most of these tools depend on caregiver report. And sometimes caregiver report may conflict with what you're observing in the room, in which case then it's important to have a conversation. And because sometimes how kids function in different environments is also clinically useful information for us. It's also important to recognize for all these questionnaires and for all developmental screening tools, if the tool says that children do not have developmental concerns, but you as a clinician who has years and years of experience with children, or even training and working with children, or the parents express concern, that should trump the results of the screener in every case. And kids should be referred on for assessment, just like we do with newborn hearing screening, right? If something, depending on what the screener was done, like an OAE, right? But a parent is still concerned about hearing, we as professionals would probably still refer that child on for a different level of screening or assessment, right? So the same is true here. It's also really important to recognize that these are screening tools. And just like with newborn hearing screening tools, they are intended to capture all of the kids who have developmental concerns, but they may not do that with 100% accuracy. And so that's why it's important when giving these tools to explain, I'm seeing some things that flag here for developmental concerns, and then to have the discussion about the referral for a more detailed developmental evaluation, just like you would refer to diagnostic hearing evaluation as a result of newborn infant hearing screening. Does that make sense? And I think that takes the pressure off sometimes if you're able to have similar conversations with families around that. I'm gonna share the next table. Again, only presents a limited range of autism screening instruments. So there are many, many more autism screening instruments that are out there in the field. I just included these for a couple different reasons. Largely because I have either clinical experience using them with both kids with developmental differences and with kids who are deaf and hard of hearing, or because there is research on how they can be used or modified with kids who are deaf and hard of hearing. So the modified checklist for autism in toddlers revised is a 20-question parent questionnaire. It's publicly available and free to use for kids who are 16 to 30 months. We use it in several instruments. It's built into our electronic medical record system here, so it can be pushed out to families ahead of visits, which is helpful sometimes. And usually the cutoff is 3 items. So if you endorse more than 3 items on that questionnaire, it usually warrants a referral. But there is also a follow-up questionnaire that can be used to fine-tune kind of responses to the questions and follow up with families that helps improve specificity and sensitivity when it's used in combination. The social communication questionnaire is also a short 40-question questionnaire that can be completed by caregivers that assesses for autism, like concerns like with social communication and social relationships. It tends to emphasize a lot of the positive symptoms of autism, meaning the presence of unusual behaviors or atypical behaviors like repetitive hand and body movements. So it tends to be good at capturing kids who have sort of those classic symptoms of autism, and especially the positive symptoms of autism for kids who are 4 years and up, or who have a what they call mental age or developmental age of 2 years old. And so it has been used in research with 2-year-olds as well, but the clinical norms are intended to be for 4-year-olds. And the social responsiveness scale, the second edition, and I believe a new one is underway, includes 65 questions that assess social awareness, social cognition, social communication, social motivation, and restricted interest and repetitive behaviors. So those are the publisher's terms, not necessarily the preferred terms of the community, which tend to be more preferred interests or areas of exceptional skill. And this can be used with individuals who are 2.5 years old through adulthood. And this has been revised and validated in a population of kids who are deaf and hard of hearing with only a few modifications. So each of these are questionnaires that can be given to caregivers that often assess for things that you may not expect to see in the room during your visit, which can be a helpful addition to what you're observing during your own session. Again, what I've seen clinically is that these tools tend to do a pretty good job. Actually, I would think that on face value, the MChat would flag most kids who are deaf because there are questions on it. Like, has anybody ever wondered if your child is deaf? Which gives you 1 point already on that questionnaire. But interestingly, most of the families of kids who are deaf and hard of hearing don't actually endorse that item. They're like, nobody's wondering if they're deaf. We know they're deaf. So they tend not to endorse that item. And it tends to work reasonably well. I will say that depending on when it's given to the family in their journey towards integrating understanding of their child's hearing difference, that does sometimes seem to have an impact on how parents respond to this questionnaire. And so again, if you have concerns and a parent isn't endorsing many concerns, particularly early on in their understanding of their child's hearing difference, where they seem to attribute a lot of behaviors to the hearing, it's probably still worth referring on the MChat. I have found increasingly that the SRS is working fairly effectively, although I use it in settings outside of like the autism diagnostic clinic, and I'm seeing like slightly elevated endorsements on an SRS, not quite at the clinical level, but slightly elevated at that sort of at-risk range on that tool, for kids who have a variety of other developmental concerns, for kids who have a history of language deprivation that results in social difficulties depending on the settings that they're in. So it does need to be interpreted cautiously, but again, it's not the job of these tools to do the diagnostic piece. It's worth the referral in most situations to follow up when kids flag on the screeners. All right.
So can there was a comment in the chat, thinking about different models for who might administer the questionnaire versus interpret the questionnaire. So I think the thought was like, could you use like an audiology assistant to give some of these questionnaires and then have the audiologist interpret? But I think for clarification, I think everything we shared can just be a physical questionnaire that the family's filling out independently. And then some of these can be modified as a structured interview where you would actually have a back and forth for clarification or an actual interview. Other thoughts you want to add to that, Debbie, about who might administer and how to administer?
Yes, and I think that's a great question actually for Alyssa and Lindsay too, to kind of address in their discussion about how it's been implemented at Vanderbilt. And I'm happy to kind of, when we get to the Q&A, follow up on, how it happens in the settings in which I work. But admittedly, I'm mostly the one who's distributing the questionnaire and interpreting them. And that is different than audiologists or audiology assistants doing it. So yeah, I think that's a worthwhile discussion. Okay, I also will refer everyone to sort of some other resources for recommended practices and screening instruments. These are developed for pediatricians, but it's worth us knowing about so that we can, for example, ask. We expect pediatricians, based on the American Academy of Pediatrics guidelines, to be doing screenings for autism at 18 and 24 months. As we talked about, that doesn't always happen. We expect general developmental screeners at 9 months, 18 months, 30 months, and so on. And again, that doesn't always happen. But if you know that that's the expected schedule, you are then prepared to ask about whether it's been done when you see kids who come in that fall in those age ranges. So I just talked about those standardized kind of tools. And again, those are best practice, right? I don't want the fact that I'm putting this slide next to suggest that I'm suggesting that the next statements that I'm going to make are superior or better than using the standardized tools. The research has clearly shown us in pediatricians' offices practices that using the standardized tool is far better than relying on our own understanding of development. But I also, again, practice in the real world where I know there are sometimes systematic barriers to those screening tools being implemented. And so a next best scenario certainly is for clinicians to kind of have some understanding of development, so that when a patient shows up in your clinic, that you can kind of think about what their chronological age is and use things like developmental milestones. The CDC has still in existence, I believe, a developmental milestone tracker that can be used so that if you see a child who's coming in of a particular age, you can quickly go to that site, reference what you expect them to be doing, ask those questions as questions of the family to see if that's what they're doing, or to kind of gauge whether they have developmental delays in particular areas, with the recognition that if you're just asking about communication, some children have developmental differences or scatter in their developmental profile. And so we often need to ask about those skills across developmental domains because some children don't develop uniformly across all areas. And then this information can be like easily integrated into thinking about modifications that can be made to test procedures. One thing that I have learned in my practice from being trained on models of early intervention for kids with autism that has been so impactful to how I engage with kids with autism is an understanding that if I am asking them to do a particular task, so for example, in your case, a listening task, I want every other aspect of the developmental demands on that child to be easier than that expectation. So for example, when you're selecting tools for behavioral assessment, right? If the tool has like a heavy fine motor demand, that might draw the child's resources and attention away from the act of listening and engaging in your test procedures, because that the demands of the motor components of the task that you're asking them to do to show that they're understanding are greater than the area you're actually trying to assess. So to that end, we developed, I'm going to go out of order here, Dr. Bonino. We developed some tools that can be kind of quick reference guides. This particular tool was developed with some of our GaLEND audiology trainees. And it was developed to try to have a way for trainees and professionals who maybe aren't used to thinking about explicit developmental task demands and what developmental age they're associated with, to be able to easily kind of observe a child or ask families about what their child is doing and what they do well, to be able to identify what types of tools and tricks can be used during an audiology visit. So for example, the easiest levels here would be those, if kids are sort of at the exploratory stage, they might have motor skills to be able to push a large button. They might have, you know, just a few words or make vocalizations. They're probably likely to be at a stage where they need a cause and effect task to be effective for audiology testing, right? Even if they come into you, and those tasks are usually for kids under 15 months for sure. And so if they come into you and they're chronologically 5, but the skills that they're demonstrating are more aligned with those easier or earlier levels of developmental skill, then you want to be able to quickly modify the approach that you're taking with the child during the testing. And outside of the scope of this presentation, Dr. Bonino is doing a lot of work testing and implementing these in real time in her research lab to be able to kind of best understand what the developmental demands are of different types of audiology testing and what the developmental skills are that kids need to be able to demonstrate to be successful at that. And so that's a great thing that unfortunately we probably won't have much time to talk about in more detail here, but I don't know if you want to add more to this, Angela, before I go back to some other examples of developmentally informed practice.
No, I think, well, hopefully many of you were at the Georgia Symposium back in the fall when I did and learned some of these things. But yet there's a variety of strategies and supports. And I think it's a good reminder, especially in the context of condition play audiometry. It's a really demanding task across a lot of domains that we're asking kids to do, because we're asking them to follow adult-led play, adult directions, to stay in a location, to tolerate the sensory input of the headphones, and then to perform a particular task that they may or may not find very motivating and engaging. And it requires a lot of work to align each of these demands better for what their profile and their interest are.
Okay, great. Yeah. So worth checking out. I don't know if that is recorded and available somewhere, Dr. Bonino, but we also did a webinar that is available, and I can try and dig around and find the chat a little bit and put it in the chat a little bit later on.
And if we have time in Q&A, I'm happy to answer more questions. And I happen to have my carted toys in my office, as they normally live in the corner.
Okay. So that's a great example of how, the information, and especially think about the difference between when you gather that information ahead of time of a visit in an ideal scenario, or where you have given a parent a questionnaire in the waiting area and you have that in front of you going into the visit so that you can quickly adapt to the child's developmental levels to make those modifications. But there's also the idea of developmentally informed practice can be universal too. It can be the idea of recognizing that all kids, when they go into a new situation, like that can be overwhelming. And so having a sense of understanding of what to expect is probably a developmentally informed strategy that's helpful for all kids. And so, again, this is just a resource that's publicly available through the links provided here, of using visual support to help support kids with what to expect during their visit. So in this example, and there's videos available on this site that show what happens with different types of audiology procedures. In this example, this is just a visual where you can check off as each of these tasks is completed, or you could, modify it so that you only focus on the ones that are being done that day. So the child, if they've had an experience where they didn't like a particular task, you can show them that's not happening today. Don't worry, it'll be, we're going to handle this today, right? So that's just an example of developmentally informed practice that is probably helpful to many children who come to your clinics, whether they have a developmental disability or not. I will say that thinking about who's most likely to benefit from this from a developmental perspective, those are the kids who have some understanding that pictures represent other things and that have that level of abstraction. Some kids really do need that to be pictures of their audiologist in their audiologist setting in order for this to be effective. And for kids who don't yet have the recognition that pictures represent other things, this type of tool probably isn't the way to go. But maybe giving them an object representing the next task, like giving them the headphones before they do ear-specific testing to kind of explore and cue them that that's what's happening next, might be a way to approach that from a developmental standpoint. All right. Okay. So we already talked, and I'm not going to talk too long, that some groups may need to be screened more often for developmental concerns and for autism. I see this particularly in our clinic with kids with congenital CMV, where both the risk of developmental concerns and differences and their hearing risks kind of need to be monitored over time. And I would say of the kids that we talked about earlier that have some of those pre-existing conditions that contribute to a risk for hearing differences, those are often the kids that I think about who need to be screened more often. So that's just a good kind of guideline. If you see a child who has any risk factors for developmental differences or for autism, they need to be screened more often. And then the next part is kind of thinking about the protocol for follow-up in place. And I'm going to let Alyssa and Lindsay talk a little bit more about this, but I'll just say that, after you've collected the results of the developmental screener, that is not, that didn't happen by itself. That is not the time to put your head in the sand. That's the time to be willing and prepared to have conversations about the results. And I think, this is a good opportunity to check in with your colleagues, see how they're presenting that information. We'll talk a little bit about how it's presented at Vanderbilt, and we have some suggestions for language. But it's really important to kind of have answers to the questions that parents are likely to ask following the results of the screener. So that might be, where do I go now? Who can I see? So knowing within your own systems who, referring them back to their primary care physician for that information if it's unknown to you, or being prepared with a list of resources in your center or your area, your region is important. The way the information is communicated is very important. We all know that how information is communicated after a newborn hearing screening, if families are told, like, don't worry, it's probably just fluid, right? That is not adequately preparing them for next steps. And sometimes doesn't communicate the importance of the follow-up steps. And so we want to be careful about how we're sharing that information so that we adequately convey the importance of follow-up. So then, the questions are, who needs this information and how do I effectively communicate my concern? Generally speaking, the families need the information, the referring provider and the child's primary care physician need the information. And sometimes, the next step, the next follow-up needs the information, particularly if it's a child who has a unique developmental concern and the next step person doesn't know how to interpret, for example, the impact of hearing, right? It might be helpful for you to get releases signed, to reach out to the diagnostic providers, to share what you observe that's different than what you expect based on a child's hearing difference. We'll talk more about these things, I think, in the Q&A, but I also want to I cannot highlight enough the importance of clear language in our recommendations for next steps. I don't know if this happens in your center, but I know in mine, a common type of language that I might see from an audiologist report if they're not able to get ear-specific information during a visit is that a child has quote unquote normal hearing and at least the better hearing ear, right? And I think that language came about because it was intended to help physicians realize, like, we don't have to put all therapies and referrals for diagnostic evaluations on hold. We want to recognize that they should have some access to language here. But from the standpoint of the families and from the providers, it's actually quite confusing. I'm always surprised at how my physician colleagues have very minimal training in hearing differences and interpreting audiology results in their training. And so when they see this, and I think when families see this, they see normal and that's it. Like, it stops there. And so then these kids are often lost to follow-up, or the importance of following up sometimes is invalidated by the pediatrician because they see normal hearing and at least the better hearing ear. So, I think being able to clearly communicate the next steps and say explicitly things like, we can't rule out all types of hearing loss, because that's really what you're finding, right? Like, we haven't yet ruled out whether there's a unilateral hearing difference. So therefore, an appointment to complete hearing testing is scheduled on this date, or next steps would be to determine whether they need an ABR and then coordinating with the medical team around that if there are concerns for anesthesia risk. And then statements like, while awaiting further evaluation, it's appropriate to move on with developmental evaluation and intervention so that we're not preventing kids from accessing these other things that they need are really important. But I'm looking forward to our discussion so that we can hear more from how what other people are seeing and how they're addressing the same issue. I do want to turn it over, though, to learn about how screening is implemented at Vanderbilt for autism evaluations.
Let me introduce these two lovely individuals, and then we'll do a little bit of hot seat relocation, and I'll get out of their way. So we have Lissa Fosnight, Dr. Fosnight, and then Dr. Wheeler, who will be joining. And both of them were really instrumental here at Vanderbilt back in 2019. 2017. So definitely pre-pandemic, pre-me being here. They were really instrumental with having some really interesting conversations about autism and what services could look like within our facility. Vanderbilt's had a long track record of making sure that those children who are coming in for a speech language evaluation also get a hearing evaluation prior to that assessment. But there were some really interesting conversations happening on our SLP side of things, and had a number of SLPs actually get trained on how to administer the ADOS. so that they could be helping with the evaluation of autism and then working with primary care or their pediatricians to get the formal autism diagnosis for those kids as a pathway to getting them to intervention faster. And then on the audiology side, these folks were thinking a lot about like, how can we move faster, saying that we don't have hearing concerns that would impact their SLPs or autism evaluation. What can we be doing about thinking about the pathway? So if we're seeing autism concerns, can we help these kids get fast-tracked into an autism evaluation rather than waiting another 24 months on a waiting list? And so I will turn over to them. They will give you a better sense of what you all have learned, as well as where the current landscape is here at Vanderbilt too. So you get out of the way and you get the answer. And feel free to move the monitor a bit.
All right, so thank you. So as Dr. Bonino mentioned, our Division of Developmental Medicine was for a long time the primary way that children were assessed for autism at our center. And there was quite a long wait list. I mean, people would wait a year just to learn where they were on a wait list, year and a half to 2 years to get an appointment. The wait list for developmental medicine does still continue to be quite long. And for a period of time, people could also sometimes get autism evaluations through the Triad Kennedy Center through research efforts that they were participating in some type of research project. But since 2017, kind of two additional pathways have popped up within the Vanderbilt system for obtaining an autism evaluation. Within Triad, they have developed an integrated clinic within the primary care clinic at Vanderbilt. So this really only impacts patients that have a pediatrician that is within the Vanderbilt system. It does not necessarily impact those that are seeing providers outside of our system. And it functions as a kind of a two-part appointment system. The first appointment is done via telehealth. And so that's a lengthy interview with parents and observation of the child through video. And in some cases, there's enough information that can be obtained through that process that they can make a diagnosis at that visit. And in other cases, when they're not, it's inconclusive, they will bring families in to complete the ADOS in an in-person visit. With that integrated clinic, the child does need to be 3 years old, under 3 years old, to complete that process. Otherwise, they need to go through another pathway or process. And in 2017, the Department of Hearing and Speech Sciences developed an integrated speech autism evaluation. So the idea behind this was that kids would be able to get an autism evaluation and a speech and language evaluation on the same day at the same visit. And I started out that way. After figuring out some billing things, the amount of time that things were taking, it did end up becoming 2 visits, but that were part of a dual evaluation where kids were being seen. You wouldn't mind going to the next slide? So at the point that this dual evaluation was being developed, we in the clinic, we would be seeing our patients and doing hearing evaluation, and we'd be noticing, certain types of developmental concerns where we were concerned about aspects of development or autism. And we weren't necessarily asking direct questions, but we were documenting behaviors that we were seeing in our booth when we were doing testing or information that we were getting in the case history. And then if we had enough concerns that we were seeing in these visits, we were in the recommendations to the pediatrician discussing, pursuing a developmental evaluation due to some of the concerns that we were observing in the booth. But we weren't very specific. We weren't very, it was vague. Our conversations with families were difficult. They didn't really know what it was that we were talking about when we were talking about a developmental evaluation or developmental concerns. It left a lot of confusion. And so when we were doing these things, the speech team who was developing this clinic was actually looking through our reports because they had been seeing these things that we had been listing in our reports. And they were like, you guys are giving us a lot of the information that we need to know for which kids might benefit from these dual evaluations. And so we started kind of meeting regularly to figure out how we could work together to be more clear about concerns that we were seeing and being more systematic about it too. And then we started looking at how we could be implementing screeners in our appointments to refer children to this particular pathway. And not every single child that we saw that we maybe had concerns about went through the speech pathway. Some went through the other pathways because they might have been able to get in with their PCP more quickly than they were able to get in with speech, or they had some type of additional history such as trauma or other medical problems that the research integrated pediatrician clinic and speech clinic options were not the best ways for assessing them. All right. And if you could, thank you. I think this was yours.
Yeah. And so, yeah, I mean, it's almost like we had this partnership in the very beginning, but then we started actually like putting like rules into place and protocols. And the reason we kind of had that connection is that they already had the protocol that the speech and language department had a protocol is that all children under the age of 4 years old had to receive a hearing evaluation prior to their speech and language evaluation. So we were honestly seeing almost all the patients that they were seeing. And then
Seeing them first.
Yep, and seeing them first. And then like Lindsay was mentioning is that, you know, the speech language pathologists were already reading through our reports. Our reports are very comprehensive, touching more on just hearing and communication, but we have sections about behavioral motor development and just medical history in general. So it kind of like it's great that it happened and that we actually now have a protocol that's in place. You can proceed. Yeah, so like I mentioned, and like you all mentioned as well, that we are really in a unique position to assess other things besides hearing during a hearing evaluation. I don't know, remember the last time I had a 45-minute appointment with my daughter with her pediatrician, asking her to do multiple different things other than just trying to sit there and be quiet while we're trying to talk. So yeah, we do have this unique opportunity to really work with this child in an environment, ask him to seeing if they would do developmentally appropriate tasks, and if they can't, of course, we change our path. But at the same time, like we kind of know like what we should expect, but if we're not expecting, so we document those things. And then also we do require a lot of touching of the ears. And so we kind of, you know, we have an idea how a child may react in a new environment. And so if we see something that's kind of out of the norm, we can observe that and discuss that. You can proceed. So the one thing that we also wanted to do is that, I mean, we were just going off of our personal experience. What I did is that I developed, well, didn't really develop, but I looked through how can we start training the individuals on our team to have better knowledge of development in general, and then also specific to autism. And so was going through the CDC website. At that time, they actually had different training videos that were specific towards autism. Now it's more geared towards just child development in general, but it was a requirement that everyone on our team had to go through the CDC training website. You can proceed.
And we did that as a team, as a group, and then anytime that we onboarded new staff, they had to go watch those videos too. So we all kind of had this base level of knowledge through doing those training videos.
Yeah, and then also we had access to Autism Speaks websites, going through some of their trainings as well. And then the Vanderbilt Kennedy Center Triad, has their own online learning as well, but you also do need to have a login for that.
And it's available to anybody who wants to create a login. So don't worry if you don't have a login, but you can't access the training unless you create a login to utilize some of their online learning opportunities.
And the key thing is that all of this is free. So that's really nice to have a training opportunity that you don't have to then spend money for that. So what protocols? Okay, so we went through this training. They were like, okay, so what are the different things that we can implement during our appointments to really catch these children where there are developmental concerns, specifically towards autism? And so we have like 3 different categories: identifying red flags, how do we phrase our case history questions, and then also implementing screening tools. You can proceed to that. And so we were thinking of different ways that we can identify red flags just for developmental concerns, autism. And the first one is the chart review. So a lot of us went digging through the patient's chart, really looking at pediatricians' note. Have they seen any other like therapists within our system, and just looking at outside medical records and just kind of see what's popping up in those reports, jotting it down on a sticky note, virtual sticky note. And then having that in our back pocket before the patient arrives. Then we had the observation in the booth immediately when you call back the patient. The first observation I make is I call their name. What do they do? Obviously, this is depending on the child's age, but do they look at me? Are they the kid that's running around the waiting room already? Are they laying on the floor? Are they screaming bloody murder? Your observation starts there. And then you have your parent report, which goes into a very targeted case history along with screening tools. You can proceed.
And so one of the things that we kind of learned as we started this process was that if we didn't ask specifically about development or autism, parents weren't necessarily sharing certain concerns with us. And so unless we ask targeted questions that use more clear language or use the term autism, families would not share that information with us during case history. It might come up later as we probed and talked about things a little bit further, but it would not come up in our initial case history. So we actually kind of revised our case history to include some very specific questions about a child's development, and then to also ask the very specific question, do you have concerns for autism? Next slide, please. So our team kind of can take 2 different approaches with asking questions, but the one that seems to be most comfortable for newer clinicians does tend to be asking more open-ended questions. So, do you have any concerns about your child's development? Do you have any behavioral concerns? And then based on how they're responding to those things, then you can ask them specific behavior questions. It might be based on something that you're already seeing in the room, a child, not necessarily making good eye contact with you or engaging with you. And you said, do you feel like your child makes good eye contact with you? Oh, they do. What about with people that they don't know very well? Is that something that they do well? So you can kind of ask them very specific questions. Does your child throw tantrums that are intense or last a long time? Does your child play with other children? How do they play with them? Do they just kind of sit and observe? Do they seem interested? Or do they tend to always play by themselves? How does your child play with toys? Describe how they do that. Give me an example of how they're playing with the train. So you can kind of get some very good information about what they're doing developmentally when you ask very specific questions about it. And then at the very end, just as you've asked about speech and language and motor milestones, do you or any of your child providers have concerns for autism? Because they may be working with other therapists or interventions. And the parent themselves may not have concerns for autism, but a speech language pathologist or a pediatrician has already maybe started to use some of those terms around the parent. And so by asking this question, we can get if they have concerns or if somebody else has concern. And we've already introduced the word autism. So when we maybe are discussing our findings or discussing screening tools later on, we're not using that word for the first time. It's not as shocking. And
Or judgmental.
Or judgmental. And the more that we ask these questions and use these words, I think on one of the earlier slides that I saw, it's less awkward. It's less awkward because it's a part of our standard protocol of questions that we are routinely asking. It is not a question that we're asking just because we're seeing this specific behavior in front of us. Next slide.
And then also that leads us to our different screening tools. So the very two common ones that we use are the MCHAT-R and then also the Early Language Milestone Scale 2, so ELM2, in order to both look at behavioral and communication milestones. One thing that we have been throwing around was administering the social communication questionnaire. However, due to its length and not currently having electronic questionnaires available, we have been sticking to the first two as of right now. You can proceed. So yeah, I think we have already stated this, why are they so helpful? I think the first one is that again, it's less judgy on the clinician's part. This allows the parent to basically rate, their child, answer all these different questions. They're the ones that are answering it. It does give a clinician a good starting point, definitely for clinicians who have a limited pediatric developmental experience or just kind of new to this. It's a good starting point. Whereas I know some clinicians who've been in this game for a while, they're just kind of like, yeah, we have these questions. We're just going to, keep going through and asking them. You can proceed.
As Dr. Foss-Knight mentioned, we are in the process of exploring how we can administer the MCHAT electronically at our center. So it would be administered universally for the correct age range in the pre-check process. And what's nice about doing this electronically is that there is a limited amount of time during appointments, and there are all sorts of reasons why we don't have enough time from, families not showing up on time or for trying many different ways of testing to get information and the amount of time that it takes to have conversation. The other benefits for doing this electronically that we can actually offer it in multiple languages as opposed to if we're administering it orally. We can only speak the language that we can speak or do it through an interpreter. And then the clinician can review it prior to the appointment. So we can be looking at what some of those concerns are and those red flags are even before we bring a family back. We are still figuring out how to address some of the challenges that would go along with this, such as access. Not every single family that receives the referral to our center has access to the online portal. So we need to kind of think about when we're scheduling these patients for appointments, does our access center need to have an additional job to support families getting signed up for an online portal so they can answer these questions in advance? It does assume a certain literacy level, while the MCHAT-R is a validated measure and has language levels that is appropriate for many families. There are some families that do not have a literacy level where they can answer these questions well. And then from administering the MCHAT in an in-person format, not all families will read the entire question or read the examples that might come along with the questions. They will read the question and just interpret it based on what they think it means, as opposed to kind of thinking about the examples that are provided. And so when you're administering it electronically, it doesn't really give us a chance to kind of just ask them follow-up questions or to give some examples for the family to think about. And then also when we are in a clinical setting and we have two parents that are with the child at an appointment or two guardians that are present, we've also seen that sometimes parents can have different opinions as to how they might rate their child on a screening task. And so sometimes it's good to be able to hear that dialogue and that discussion in an exam room. And that's not something that you can see on an electronic form, if that's happening behind the scenes, if they're filling it out together, or if only one parent is filling it out, because I'm sure that's what's happening in a lot of situations. They're like, oh, we got to get this form done, and we're going to do it while so and so is watching our child. Next slide.
I was going to say, someone asked a question.
Oh.
It says, so clarification, you administer the MChat or ELM2 only to those whom caregiver or audiologists have autism concerns, or to all children. So as of right now, we do not have a universal way of administering these screeners. At the same time, a lot of the children who walk through our door are already scheduled for a speech and language evaluation, or they're already scheduled for a developmental evaluation, already scheduled for the speech and autism evaluation. And so I would say in general right now, we are not administering those because they already had the path set for them. They were scheduled this because that was already part of our protocol in place, that we have to have the hearing test. But if you only look at the kids who are coming in who do not have anything else scheduled, I would say more often than not, we are administering the MChat or some degree of the ELM.
Yeah, and I believe our discharge criteria, we don't discharge kids that have completed a hearing evaluation and who are not actively in speech without completing the ELM either. So we do that for our young kids that are learning language, just to make sure that we're screening that area.
Yeah. And so, I don't know if this is your me, but I'm talking anyway. Okay. Because people keep showing times on the chat. So with administering the MChat or electronically, it's great. I'm glad that we're going to do it. So thank you.
Yeah.
I think some things to throw in there is that there may be times where you're still going to potentially have to re-administer the MChat R if we feel like it's not in line with what is being observed in the booth. You may ask some clarification questions and just some follow-up questions with them. So just kind of keep that in mind, that there's likely going to be some further discussion about that during the eval. You can proceed. That's you.
Is it? Okay.
Yeah.
Well, all right. So what I mentioned earlier is that we have found a lot of benefits to administering the MChat revised in person, to where, like, you know, we generally don't always re-administer the MChat when we've seen that it's been done recently in the pediatrician. But sometimes we've done that targeted case history, and they told us a lot about their child, and then we're doing the MChat, and the way that they are answering the MChat is in conflict with things that they've told us in case history. So then we just really kind of probe that question a little bit further and talk a little bit more about what that question is asking, and then ask them to provide some additional clarification. And then what's also really nice about the MChat is that it really provides a good starting point for further discussion. You've got concerns about your child's language development. There are many reasons why a child may be having challenges with their language. Sometimes there are other factors, such as a developmental disability like autism, that might be contributing to some of those speech and language concerns. We're using this to see if there are any other risk factors that we need to be taking a look at as part of this picture. And as already mentioned, there can be differing guardian viewpoints, and you really get the opportunity to see that when you're doing it in person. And then again, the access component is really discussing, or in those individuals where they are not able to read the information, or they're not understanding the questions that are being asked, we're able to just provide more examples and provide it at a level that they're able to answer the questions about their child more clearly. Next slide.
Yeah, so when talking with families, we have learned that if we start in the very beginning, parents tend to start to open up throughout the evaluation. And there's a lot of times where I've literally stopped testing because the parent starts talking about, oh, I guess I am seeing these. Okay, well, let's pause. Let's talk about this because you're showing me that you're open about talking about this. I don't want to lose this opportunity. And so I have done appointments kind of back and forth where we test, parent discuss their concerns, and we just keep going. You just have that conversation with them. That again, using the screener tools, it is helpful along with everything else that we've been talking about. And we've definitely learned that being the direct is good. Wishy-washy is not good. Wishy-washy parents will be like, well, is this, that? Well, you may, I guess. And then they leave with no conclusion. But if you're direct without being forceful, that's the thing. Like, you don't have to feel like you're leaving the appointment with a decision that the family's going to move forward with the developmental or autism evaluation. I don't see it like that anymore when I administer these screeners or talk to families. It's more of opening that door. Let's have a conversation, which that parent will probably go talk to other people in their family. They're probably going to talk to their pediatrician, go talk to other therapists. And then now you're starting that communication instead of being so forceful and then they slam the door. And I've had that done before and I felt really bad because they didn't even return for their follow-up appointments with us. You can proceed. We're almost done, I swear.
But that has been, but that's also, we've also, we're talking about it when we were putting together this presentation that families that are resistant to this information are actually in the minority. Most families come because they have concerns. They're coming to these appointments because they know there's something going on, and they're just trying to figure out answers as to what is going on and find support for their concerns.
You can go on to the next slide.
Okay.
Oh yeah, did we finish that? I think we did. Okay, we're good. Yeah. I think we missed a slide on ours, but that's okay.
Okay.
Oh, Debbie, I think these were just the extra slides that we had put at the end. So.
Oh, you're fine. You can say that.
Okay. I bet there will be questions for the two of you. Okay.
I just wanted to jump in a little bit about that idea of like parent resistance. Like, I agree with you. Most of the time when I see it, it's far less common to see parents who are reactive to the question being talked about autism. But I will often myself, I am a big proponent of using what's in the room. And so I will reflect on that reaction sometimes in the room and reflect it back and with curiosity. Tell me a little bit about what you're thinking or what you're feeling as I talk about this, or I'm noticing this about your body language. So then sometimes saying the question, something like, what would it mean to you if your child were to pursue this evaluation and be diagnosed with autism, so I can understand where families are coming from, because sometimes they reflect back to me concerns about, what they've seen about stereotypes related to autism. And it's a good opening conversation and dialogue about what autism really is in those moments. So I just wanted to share that.
And I mean, like, I would also say that with my family, when my husband first received a diagnosis of autism for our son, he was not ready in that moment to hear that information. He heard it, but he needed to go get more information before he was able to come back and engage with other people and talk about it. So it's a process that we all have to go through as parents.
Yeah, I love that. Well, thank you so much to all of our presenters. Questions? There is one that came through, and it looks like it's just more of a curiosity if any one of the presenters have read the book, The Reason I Jump. It was written by a child with autism, and so just sort of discussing visual schedules and how it's not always the answer for every single child with autism, which I think we all are in agreement that when you've met one child with autism, you've met one child, right? And so I do like that reminder to stay open to the fact that, visual schedules is not going to work for every one of the children that we're seeing.
I think that's a really great point. There was one study, I think it was a student's capstone from like Northwestern that got published about using visual schedules specifically in audiology. It was a small sample, and many of the kids were probably developmentally too early to benefit from the visual schedules, and so they don't actually show a benefit in their study for it. But what they do show that's statistically significant is it reduced parent stress. So I do think it's worth thinking about as we implement these supports, what might be helping the child versus what might be helping the family, and see if there's helping at least of one of those parties as we think through these different supports.
And I think it also kind of depends on where they are in their process.
Yeah.
Like because a system like visual schedules really requires a lot of practice and use. And so if that's not being implemented in other settings for the child, then they're not going to have the experience and know what to do with it.
Yeah, exactly.
Yeah. And I think also an important reminder to be flexible. And if something's not working, that's okay. We can, put that aside and try something else. Yeah.
Can I add
Go
one
ahead.
piece onto that, Mandy? Sorry to interrupt you, but I'll let you your next question. I add something. So interestingly, we tested about 80 kids this last year in the lab who had an autism diagnosis. And one of the things that I was floored by, now all of them already had a diagnosis of autism when they came into the lab, but they were on the younger side. A third of them, when we asked about communication, a third of parents said their child either used sign support or an AAC device. So I do think thinking about not just visual schedules, but other types of communication and making sure that we as audiologists are doing a good job of incorporating those strategies in our test session so the child has more access to communication, especially for those children who've already been plugged into early intervention services. Because we might be able to support their communication receptively and expressively more in our spaces if we know what other types of supports they're using.
Absolutely. Yeah. Have you received any pushback or questioning or any maybe just negative feedback from other disciplines, maybe say pediatricians, as far as like you're overstepping or, any sort of comments like that?
I would say for us, when we first implemented this back in 2017, we thought that we were going to get more pushback from pediatricians. We did, but not to the degree that we thought. And then I would say I'm not really seeing any of that now.
And I think in the, I guess, almost 9 years that we've done this program, I think we've only received one formal complaint.
And was that from professional or from a family?
I think that was a family.
Okay.
Family. I don't even remember. It was several years ago.
Yeah, I think it was from a family.
Yeah.
Yeah. I think one thing that happened during that development too, especially because our speech language pathologists were focusing on developing an assessment pathway. They worked side by side with developmental medicine and other psychologists and other teams here at Vanderbilt to make sure that there was good understanding that they were considering doing it. What all should they do to be reliable testers? Which kids should they see versus which kids needed to be referred elsewhere. And so I do think working within your system to know and build partnership during the development can go a long way.
And one thing I forgot to mention while we were doing this is that we actually, as part of this dual evaluation, if we thought a child might benefit from that pathway, we asked families if they wanted their information to be forwarded to that clinic coordinator. And that clinic coordinator then reached out to the family and told them what they needed to get scheduled or determined if there was a better pathway for them to get the evaluation more quickly or more appropriately. So we had a very good point person to refer parents to if they had more questions following our conversations too.
Yeah, that's great to have that good support for the families once we're kind of, wanting to refer them on, making sure that we've got those professionals we can contact. Going back to that communication piece, are there specific AAC boards that people are using in audiology clinics, or does anyone know if there's like a resource available when it comes to that?
We have had one of our GaLEND audiology trainees who's a teacher of the deaf by training, who has developed some communication boards to use during audiology visits. And she did present on that at Eddie this year. We hope to work with her to make those more publicly available. But there have been like individuals who've done that within their own practice.
I will say that in doing some work that I'm doing in the schools, I do know that the LAMP app can be downloaded on an iPad for free if the individual completes like an hour of professional training. So that might be something to explore it, but I'm not super familiar with the age appropriateness and the population, but that is an AAC system that can be just downloaded on an iPad for free at the moment. So.
And what was the app's name? I'm going to put it in the chat.
LAMP, LAMP.
You can create like AAC like picture boards, right, within common tools like Canva and things like that. So they can be created outside of the app as well. Like those resources are available.
You reminded me that I think it's on one of maybe the pediatric groups on Facebook, and I think that someone had taken a picture of their dog going through it, and it is so cute. And I think she was also sharing the link. So if you happen to be part of that group, I wish I could remember her name, but it was the cutest pictures of her very patient dog doing all of this. So that could be something to even use just for our individuals who maybe, are just fearful about going into a booth or being seen. It's kind of a lighthearted, humorous way to show what's going to happen.
Especially if you have a preferred interest in animals.
Absolutely. Yeah. All right, let me see here.
I have a question while you're thinking of the next one, Mandy, for Alyssa and Lindsay, since I wasn't here during that time period. I'm wondering, because the comment I often get is like, how do you convince a whole team of audiologists to do this?
Mm-hmm.
And who, like, thinking about, like, especially your late adopters. Obviously, you two are early adopters for being willing to do it, but like, how did you bring the whole team on board for doing it? Or what would you say to somebody who's reluctant about doing it?
I was actually going to say, I think that the way that we did it ended up helping build team buy-in, even if everybody's not doing it quite as much as our early adopters. Everybody now has tools that they can use as part of the evaluation process. And I think that then if there is a push to do this universally, you're not going to have pushback because everybody is aware of the process, has some practice doing it. And we presented data to our team to show the benefits of what we're doing and the accuracy of our referrals.
Yeah. And I think that was, that's a really good point, Lindsay, because I know you all looked at the data, but then also they were getting like a feedback loop from the speech language pathology team about, thank you for referring. Yes, this child ended up getting an autism diagnosis. And so I think having that feedback loop can be really helpful, and we're able to do that. And I will comment too. So again, I just looked at the data. In 2024, there were about 600 kids that were seen between the ages of 18 months and 8 years. So it was like 600 some kids for an SLP assessment that had a hearing evaluation prior to. A third of those kids within a year had an autism diagnosis in their record. So like they're all seeing a lot. Like I think that's the other piece of, even though we're talking about a really high co-occurrence rate of, or prevalence rate of a high prevalence rate of autism in our clinical group, especially when you start talking about those young children who are getting a speech language assessment, that number is probably even higher. So if that's a common pathway and group of kids you're seeing in your clinic, there's a need for those tools. And if you don't have those tools, you're having a lot of awkward conversations that you're probably not feeling well prepared to have as a clinician. And so maybe that's part of the reason of thinking too of like willingness to adopt and do it, because the need's clearly there.
Oh yeah, I mean, there was a lot of us who were really frustrated because we felt like we were not doing the best we can for this patient. Like when we left, I was like, well, I told them they had normal hearing, but I felt like I did absolutely nothing for them. So a lot of us were